Nicholas, you said that I think you said you felt like a cardinal talking to the Vatican about the importance of open data analysis, something like that. Okay. How many doctors are in the room? 3. Medical doctors, sorry. Practice, let me put it more stringent. Practicing physicians. 2. Okay? So, we have spent the entire day talking about medicine. Precision medicine. Personalized medicine. Without doctors. With only a few doctors. What is it like going to the Vatican and talking about, I don't know, whatever you want to know. So we are trying to build up the medicine of the future without doctors. Now that's, I believe, clearly wrong. And I hope that by the end of my talk, you allow me to go back home, because I will be a bit critical. Okay? And let me start by criticizing the title that Scott gave me. This is your title. Collaborative access to data is the fastest way to drive medical innovation. Well, I think this is wrong, Scott. I'm not interested in the fastest way. I'm interested in the best way. Although it might take longer. It's not a race. It's not about being fast. It's about treating patients. And all of you, sooner or later, will be patient. I was patient a year ago in the ICU. I won't get into the details. But I've been a patient, a doctor and a patient. And all of you will be patient. And I'm sure that all of you would like to have the best approach, not the fastest approach. Do we agree on this? I think so. Okay. So some conflict of interest to disclose to begin with, okay? I love technology. It's not that I'm against technology, data analysis, databases. Some of you know me and know that I like networks and graphs. And so keep in mind that I am in favor of this, not against this. But, as I said before, I'm a doctor. So please, trust me. Don't try to build medicines of tomorrow without even asking doctors. You have been discussing about platforms, data mining, which is excellent, it's fine, it's needed. But where is the clinical context? Where is the clinical question? And I believe that this is absolutely key. Context matters, okay? And in my clinical context, the important question is this. It's not about how to exchange data. It's not about how to produce nice papers. It's about how to best, not fast, best, user-generate, high quality, garbage in, garbage out. So it has to be high quality data for the benefit of the patient, for the future benefit of all of you, including me. Do we agree? I think we agree. So how do we answer these questions? What is it? Nothing new under the sun. It's about research. It's about high quality research. It's not about data mining. Data mining is fine as long as it is in the context of a good research question. And the question is the start of the process. I will talk of the research process. I will mention later this unbiased research, okay? Not hypothesis driven, which is fine to some extent. But at the end of the day, these unbiased or unbiased approaches produce or are described as hypothesis generating that need to be tested. So at the end of the day, you need a hypothesis to test, no matter what. So very briefly, let me give you a historical perspective of medical research, only 1 minute, okay? Let's see that modern medical research start in northern Italy in the 15th century, when they start doing necropsies. Okay? At that time, the most advanced medical cutting-edge science was anatomy. Leonardo da Vinci was an anatomist. But they very soon realized that the human body was too complex. So they have to have a reductionist approach, and they moved to an organ. So it's not the body, it's the lung, or the heart, or the liver, or the kidney. Don't ask me what type of experiment is this very academic researchers doing with these patients. Probably no ethics committee would accept that today, but this is physiology, 19th century, okay? Still the organ was too complex, so we moved to cells. And since the mid-20th century, we have cell biology. Still too complex. We moved to proteins and genes, and these are Watson and Crick in Cambridge, 1956 or 7, I believe, before the Nobel Prize. Okay? But this is still too complex. Although by 2001, we got this seminal publication, the genome. Oh, now we have the genome, the human genome, everything is solved. From that paper, we will be able to understand all human diseases, to prevent all human diseases, and to cure all human diseases. This is more than 15 years ago. Does this happen? No, of course not. This is still too common. And I like to quote this guy, some of you know him, but Alvar Agusti. He's a physicist, okay, now holding a position of full professor at Harvard Medical School. He's one of the leaders of network medicine, okay? And he said that in this very small book, you can buy it in Amazon linked. Have you ever seen a child take apart a favorite toy? Of course you have. Did you see them, the little one crying after he or she realized that the pieces cannot be put back together again? Yeah. So this is what he says. This is what we did with science. We have taken apart the universe and have no idea of how to put it back together. And this is actually what we are doing, what we are trying to do with network medicine, with systems biology, with data analysis. So what we need to do is to integrate information. And we have many different ways to do this, but integration is the word. This guy has proposed this concept of network medicine. If you have not read this paper, I strongly recommend you do. And this is myself, poor clinician. I have been trained, and the other clinicians in the room, I think, will agree, precisely to integrate data. When a doctor sees a patient, by the way, medicine has been personalized for the last 3,000 years. Every time a doctor says, "How are you, Mrs. Smith?" you're talking about a woman whose name is Smith and who is whatever, age and whatever. So you have been personalized in medicine with better or worse success, but you have been personalized in medicine for many years. So every time the doctor takes a clinical history or physical examination or look at chest x-ray or take some blood test, simple one, not genome. I mean, what you do as a doctor is to try to integrate in your brain. And you say, okay, these symptoms, these signs, these chest abnormalities, blah, 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 blah. Mrs. Smith, you have COPD, or you have asthma, or you have pneumonia, you have whatever you have, and you treat it. What's the problem? The problem is now we have far too much data. And how to integrate this within a clinical practice framework is, in my view, the key. This might look something like this. Okay, this is a diagram. And this is what we published some years ago, 2010, 11. How do we see one particular disease that we call COPD, chronic obstructive pulmonary disease? This is not working, but COPD is here. And we envisage this disease as a building. where you have several floors or levels. We have a clinical level. We know that this disease is often associated to other diseases, comorbidities we call it. Below that level, there is a biological level, many different mechanisms that interact. Below that, there is a genetic network level, and many different mechanisms that interact. And above all of this is the environment, with many other mechanisms that interact. And you know what? This building has elevators, and they do not necessarily stop at each and every floor. For instance, the environment influencing the genetic network, and you know that this is called epigenetics. And here you have potential outcomes of clinical value. Again, the clinical context. You might identify genetic variants that tell you about risk of dying, risk of developing other diseases, risk of responding to a given treatment. The endotype, a couple of you mentioned endotypes. I fully agree, this is very important. And this will tell us about diagnostic biomarkers and eventually new targets for treatment. Clinical phenotypes and lifestyle changes. So in closing, let me give you a clinician's view on what we discussed today, which is data access or data sharing. Okay? I think I said that this morning, but it is not about usability. It's not about the tool. How fancy is my new platform to integrate whatever I want to integrate? It's like a new drug. You need clinical trials that determine the efficacy and the safety of whatever approach you want to take. This is precision medicine. We talk about precision medicine. This is the population with the same diagnosis and today the same prescription. But there are actually 4 groups. The red ones, drug is toxic and not beneficial. You clearly don't want to give the drug to these patients. Drug is toxic but beneficial. Well, here you have the clinical judgment. And you have to see and decide whether or not you still want to provide that treatment despite it is toxic. Chemotherapy for cancer, that's a good example. This is not toxic and not beneficial, but expensive. Okay? And this is where you want to go. So you want to have ideally a population of patients with any disease where the drug is not toxic and beneficial. In that case, price does not matter. Okay? Someone mentioned randomized clinical trial versus real life study. Oh yeah, here's the answer. Real life studies, let's go to the population. Well, of course, randomized clinical trials have many limitations and some advantages. But the same is true for real life studies. Here you have a graph that we also published some years ago. Here you have what we call the study design or the ecology of graph, okay? Which is you have a highly controlled ecology, randomized clinical trial, a free ecology, which you just observe, and in between, what is called a pragmatically controlled. Okay? And here you have the type of population that you study. You study patients with pure diagnosis. You exclude everything else. They have COPD, but nothing else. Well, you study the right disease, but in the wrong context. And here is, well, I have no idea if this is the disease of interest, but the physicians out there manage that patient as if the patient had whatever. And here you have different types of studies. Which one is better? All of them. We need all of them. They are complementary. But you have to be aware of the limitation of each type of intervention. Open, which is the topic of today, versus collaborative access. Of course, open access. Come on, give me a break. I want to access the data day one, as soon as possible. But if you talk about biomedical research, the devil is in the details. And the details are key. I'll give you an example. We published this paper a couple of years ago, New England Journal of Medicine. My goodness. This is the truth. No question. This must be right. Okay? We studied 3 different cohorts: Framingham, Copenhagen, New Mexico. Okay? Big data. And we found, I will not go into the details, that there are several ways to get COPD. This is lung function, normal, 100% abnormal, and this is the age of the individual who was followed in these cohorts. And you see, you can get COPD here through the red trajectory or the black trajectory. Abnormal lung decline or poor lung development. Beautiful. Where is the devil? You know, neither we, the authors, or the reviewers, pick it up. And 1 year later, with Rosa, we were discussing and we found the devil. The devil is that in order to be included in this analysis, you need to have a lung function measurement when you were young, and a lung function measurement when you were old. And you know, you cannot obtain lung function measurement in dead people. You have to be alive to blow. So if you die here, you will not be here, and you will not be included in this analysis. So we now reanalyze the same data and said, do these guys die earlier? And you know what? The answer is yes. So now the paper is resubmitted, and as a friend of mine would say, pending rejection. Okay? So unbiased studies that end up by being hypothesis generating versus hypothesis driven. And I'd like to share with you one funny editorial on this respect. This guy is a famous apoptosis biologist, okay? Working in Cold Spring Harbor, I think, whatever. And he wrote this: can a biologist fix a radio? What do you think? Is there any biologist here, Rosa? Anyone else? Two?
I fixed my radio last week, actually.
You what? You say what?
I fixed my radio last week, actually.
Can you fix a radio?
Thanks.
You still have a radio?
So let me show you what these guys say, okay? What would you do if you want to fix a radio? First thing you do is to open the radio.
Yeah, it's awesome.
And then look at the component. And these guys start classifying each of these components by size, by color, by position, by change. And then he described what he called the most important component, which is a long piece of electric cable. And he realized that if he cut that cable, radio does not work. So this must be the most important component. And then he found here a little area which was burned. He said, this is a target. So after doing all these sort of things, he came up with a pathway, a diagram of why there was no sound expression by the radio. And look at the pathway, which is actually quite similar to the pathway we have now. Okay? Many signals influence the most important component. These are all components here and other signals. And through some unclear mechanism, you explain sound expression. These are about the level of our understanding in many different biological processes. And he had a friend who was an engineer. And he showed this diagram to his friend, engineer, and the engineer started laughing. He said, "Oh, give me a break. This is wrong. This is perfect, not that one. This is the system." And I think that it was you or Niklas or Scott who talk about the system. Of course we need to understand the system. Of course we need to. And this was these 4 levels, or 5 or 6 or 10, and multidisciplinary approach. If you like this approach, I recommend you this book. Dennis knows, I think that Charles knows him very well. This is a beautiful book. How you can understand the sound, the music of life from this perspective. You can find it in Amazon easily. So in closing, please, I have no personal doubt that the approach that we have been discussing today is the future. No question. Absolutely true. But at the end of the day, do not forget what in my mind is the key question. The key question is, does this make a difference for patient management or not? Patient management means for a clinician better symptom control, better prognosis, and this is indeed precision medicine. Precision medicine is about improving individual patients, not about improving algorithms. So my last slide, and please forgive me if you disagree. I think that this is a multidisciplinary approach. There is no other way. Okay? We need to work together. We, clinicians, cannot do this without you. You have been basic scientists, bioinformaticians, others. No way. But you cannot do this without us. Don't forget that. I think that that's very, very important, and the devil is in the detail.